Hi, my name is Laura, and welcome to my audio version of the Women's Health Gynecology EOR Study Guide. The obstetrics portion can be found on my channel, but I'll link it below as well. This review is going to follow the PAEA Gynecology portion of the Women's Health End of Rotation Exam topic list, but I'll timestamp all the sections below in case you'd like to skip around. So, quick background. I'm a current PA student wrapping up the degree and studying for the PANCE. Like most PA students, my clinical rotations had me traveling a lot of time spent in the car. So I tried studying using different audio resources like YouTube, podcasts, things like that. There are a ton of great resources out there, but none of them quite fit the type of EOR exam-based review I was looking for, so I decided to create one. This is my very first video, so we'll see how it goes. The PAEA topic list begins with menstruation, so I'll start with normal physiology. The menstrual cycle takes place over 20 to 35 days, with the average cycle lasting about 28 days. It's divided into two phases, the follicular or proliferative phase, and the luteal or secretory phase. The menstrual cycle begins on the first day of menstruation, or the first day of bleeding, and this is referred to as day 1 of the menstrual cycle. This is the start of the follicular phase. Ovulation occurs on day 14, and after that, the luteal phase begins. During the follicular phase, which is days 1 through 14, the thickness of the endometrium rapidly increases under the influence of estrogen. Estrogen is the predominant hormone associated with this phase. Initially, pulsatile gonadotropin-releasing hormone from the hypothalamus causes FSH and LH from the anterior pituitary to stimulate the ovaries. FSH causes follicular growth in the ovary, while LH stimulates the maturing follicle to produce estrogen. Initially, this estrogen provides negative feedback to the hypothalamus and the anterior pituitary, but once estrogen levels are high enough, it begins to give positive feedback on FSH and LH, which results in the surge of those hormones. This induces the LH spike, which is responsible for ovulation, or the egg release, and this LH spike also marks the end of the follicular phase. The luteal phase, or days 15 through 28, begins after ovulation. The ruptured follicle becomes the corpus luteum, which secretes progesterone, as well as some estrogen. Progesterone is the predominant hormone associated with the luteal phase. It enhances endometrial lining to prepare it for potential implantation, and it also provides negative feedback to FSH and LH. From here, there are two possible outcomes: pregnancy or no pregnancy. So if pregnancy does not occur, the corpus luteum deteriorates and forms the corpus albicans, which can no longer secrete estrogen and progesterone. This leads to endometrial sloughing, or the menstrual bleeding, and the cycle begins again with a new follicular phase. If pregnancy does occur, the zygote, or blastocyst, keeps the corpus luteum secreting estrogen and progesterone, which maintains the endometrial lining. But more on this one in the obstetrics video. A few more notes on the normal menstrual cycle. The duration of menses, or actual bleeding, typically lasts about 2 to 7 days. The volume of blood is about 20 to 45 milliliters. The average age of first menses is 12, and the menstrual cycle is more likely to be irregular during adolescence. Amenorrhea is the next topic, so I'm going to start out with a few definitions. Oligomenorrhea means infrequent menstruation, or periods that are further apart than 35 days. Polymenorrhea means frequent menstruation, or periods that are less than 21 days apart. Amenorrhea is absence of menstruation. This can be broken down into primary and secondary amenorrhea. Primary indicates that the patient has never had a menstrual period before. This refers to a lack of menstruation by age 15. Secondary amenorrhea indicates that the patient has menstruated before, but has not had a period for at least 3 months. More specifically, if the patient previously had normal menstrual cycles, we call it secondary amenorrhea after 3 months. But if the patient has a history of irregular menstrual cycles, we call it secondary amenorrhea after 6 months of no period. Primary amenorrhea has a few different etiologies that can be grouped based on anatomy. If both the uterus and breast development are present, the cause is often an outflow obstruction, so something is blocking menstrual blood from leaving the body. Typically, this will be an imperforate hymen or a hymen that's completely closed, and this can be diagnosed by a simple pelvic exam. If breast development is present but a uterus is absent, the cause will either be Müllerian agenesis or androgen insensitivity. These are diagnosed by checking testosterone levels and karyotype. So first, Müllerian agenesis. It's caused by embryonic underdevelopment of the Müllerian duct, which, in utero, differentiates into the fallopian tubes, uterus, cervix, and the upper vagina. So in Müllerian agenesis, the uterus and upper vagina do not fully form, but secondary sex characteristics and ovaries are present as normal. Treatment is typically just non-surgical vaginal elongation. Okay, so next, androgen insensitivity syndrome. This is an X-linked mutation of androgen receptors. The individual has XY chromosomes, so genetically they're male, but phenotypically female with breast development and very little body hair. These individuals have absent uterus and upper vagina, as well as undescended testes and high testosterone levels. Treatment of androgen insensitivity syndrome involves surgical removal of the undescended testes after puberty due to risk of testicular cancer, as well as corrective surgery to match gender identity. As a side note, both of these conditions are typically diagnosed during adolescence due to primary amenorrhea. However, during my OBGYN rotation, I did get to see a patient who was pregnant carrying a baby with androgen insensitivity. The anatomy ultrasound showed a female child, but the chromosome analysis indicated an XY genotype. The rest of the pregnancy was healthy and unremarkable, though. All right, so if breast development is absent, but a uterus is present, the next step is to check hormone levels, specifically FSH and LH. If FSH and LH are high, the cause is most likely ovarian in nature, either premature ovarian failure or Turner syndrome. Turner syndrome patients have a 45X karyotype, meaning they're missing their second sex chromosome. They have 45 total chromosomes instead of 46, and only one X chromosome, making them genetically female. These individuals have some characteristic features, including webbed neck, broad, shield-shaped chest, and that high FSH. If FSH and LH are low or normal, the most likely causes are hypothalamus pituitary insufficiency or puberty delay, such as in extreme athletes, anorexia, as well as some illnesses. Finally, if both breast and uterus development is absent, the cause is often a defect in testosterone synthesis. Now let's move on to secondary amenorrhea. Remember, this is absence of menstruation for 3 months in a patient who has previously had normal menses, or 6 months in a patient with an irregular period. The number one cause of secondary amenorrhea, by far, is pregnancy. So always check a pregnancy test on these patients. One of my professors liked to say that if they are a female of childbearing age, they are pregnant until proven otherwise. So do a beta-HCG pregnancy test first. The other common causes of secondary amenorrhea are hypothyroidism and prolactinemia. So if the pregnancy test is negative, check TSH and prolactin. If TSH is high, this indicates hypothyroidism and can be treated with levothyroxine or Synthroid. If prolactin is high, an MRI can be ordered to assess for a prolactinoma, which is treated with transsphenoidal surgical resection. Now, if that pregnancy test is negative and the TSH and prolactin are normal, and the patient history and physical don't indicate any nutritional disorders, extreme exercise, or systemic diseases, then we need to assess the hypothalamic pituitary axis. The first step is a progestin challenge to induce a menstrual cycle. The test is positive if menstrual bleeding or withdrawal bleeding occurs within 2 weeks after the progestin is given. If bleeding occurs, this means that the patient has estrogen present, is able to build up a uterine lining, but is not ovulating. Anovulation is most commonly due to PCOS, or polycystic ovarian syndrome, which is a condition involving hyperandrogenism, irregular periods, infertility, insulin resistance, and obesity. If the progestin challenge fails to induce bleeding, the next step is an estrogen progestin challenge, similar to the previous step, but with estrogen added. If bleeding still does not occur, the problem is with the uterus itself, meaning that the uterus is not capable of bleeding. This is typically due to Asherman syndrome. Asherman syndrome is an acquired endometrial scarring that can be secondary to an overly vigorous D&C, ablation, endometrial infection, etc. If the estrogen-progestin challenge does induce bleeding, the amenorrhea is due to hypoestrogenism because estrogen was needed to induce that bleeding. More tests are necessary to determine the cause of the low estrogen, but let's recap everything real quick first. So the most common causes of secondary amenorrhea are pregnancy, hypothyroidism, and prolactinoma. So check a pregnancy test, FSH, and prolactin first. If those are all normal, do a progestin challenge to induce menstrual bleeding. If they bleed, the problem was anovulation, most likely PCOS. If they don't bleed, repeat that challenge with estrogen this time. If they still don't bleed, the uterus is just not capable of bleeding. If they do bleed with the added estrogen, their problem is low estrogen. To determine the cause of the low estrogen, check FSH and LH. If these hormone levels are high, the problem is in the ovaries, and an ultrasound is needed to assess whether there are follicles present in the ovaries. No follicles indicates menopause. Many follicles indicates Savage syndrome or resistant ovaries. If FSH and LH are normal, the problem is not with the ovaries, and the next step is an MRI of the brain to look for something wrong in the anterior pituitary or hypothalamus, such as a tumor or Sheehan syndrome. This wraps up the amenorrhea topic, so now let's move on to dysfunctional uterine bleeding. Dysfunctional uterine bleeding basically refers to excessive or prolonged bleeding, or bleeding that's outside of the regular menstrual cycle. It is typically a diagnosis of exclusion and is most commonly secondary to anovulation. The acronym to know for the etiologies of dysfunctional uterine bleeding is PALM-COIN. PALM represents the structural causes and stands for polyps, adenomyosis, leiomyoma, and malignancy or hyperplasia. COIN, spelled COEIN, represents the non-structural causes of uterine bleeding, and that stands for coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic or illness-related, and N is not yet classified. So we'll go through this section sequentially using the PALM-COIN acronym. First, polyps. These are growths attached to the inner wall of the uterus that extend into the uterine cavity. They're often asymptomatic, but the most common symptom is intermenstrual bleeding, or bleeding that occurs between periods. While polyps can develop into malignancy, the overwhelming majority of them are benign. Diagnosis is made with ultrasound and hysteroscopy, and treatment is hysteroscopic polypectomy, or removal of the polyps. Next is adenomyosis. Adenomyosis is an extension of endometrial tissue within the myometrium, or the muscular layer of the uterus. This tissue induces hypertrophy in the surrounding myometrium, and that leads to a symmetrically enlarged, soft, boggy, and tender uterus. Symptoms include dysmenorrhea, pain, menorrhagia, heavy flow, and possibly infertility. The definitive treatment for adenomyosis is a hysterectomy, but you can conservatively treat this with analgesia, like NSAIDs, and oral contraceptive pills. Leiomyoma, or uterine fibroids, refers to benign smooth muscle tumors. Fibroids are the most common benign gynecological lesion, and they're related to estrogen production. So while they tend to increase with age, they also regress after menopause. Fibroids are also 5 times more common in African Americans. Most cases are asymptomatic, but the most common symptom is bleeding, generally heavy or prolonged periods. Some patients also experience dysmenorrhea and abdominal pain or pressure that's related to the size and location of the tumors. On a bimanual exam, palpation is going to reveal a uterus that is enlarged, firm, asymmetric based on where those tumors reside, and non-tender. But a diagnosis is officially made with ultrasound. The decision to treat this is based on symptoms as well as the patient's desire for fertility. Pharmacological treatment is going to be aimed at the inhibition of estrogen in order to decrease that endometrial growth, and that's done with drugs like leuprolide and progestins. Definitive treatment is a hysterectomy to completely remove the uterus, but a myomectomy can also be performed to just remove those fibroids and preserve the patient's fertility. A few other surgical options include endometrial ablation and artery embolization, but both of these can affect fertility. Malignancy and hyperplasia are the last of the structural etiologies. Abnormal uterine bleeding is the most common symptom of endometrial cancer, but it can also indicate endometrial hyperplasia, which is a precursor to endometrial cancer. Both are a result of increased estrogen exposure. Hyperplasia occurs due to continuous estrogen that is unopposed by progesterone, and endometrial carcinoma is an estrogen-dependent cancer. Diagnosis is made with a transvaginal ultrasound, which shows an endometrial stripe greater than 4 millimeters, and then an endometrial biopsy, which provides a definitive diagnosis. Treatment of endometrial hyperplasia is progestin to oppose that estrogen, or a hysterectomy. Treatment of endometrial cancer starts with a total hysterectomy, but I'm going to discuss that a little more in the neoplasm section. Now we're into the non-structural etiologies of abnormal uterine bleeding, starting with coagulopathy. I'm not going to go too in-depth on this one, but von Willebrand's disease and platelet dysfunction are the most common coagulopathies associated with uterine bleeding. More on coagulopathy in the internal medicine videos, though. Next is ovulatory dysfunction, which describes a patient who is not ovulating or who has infrequent or irregular ovulation. The causes of ovulatory dysfunction can be broken down into conditions of androgen excess and hypothalamic pituitary adrenal axis dysfunction, or HPA axis dysfunction. Androgen excess is found in conditions like PCOS, androgen insensitivity, and androgen-producing tumors, so extra androgens in the body. HPA axis dysfunction includes conditions like hyperprolactinemia, thyroid disorders, Cushing's syndrome, congenital adrenal hyperplasia, ovarian follicle decline, lactational amenorrhea, tumors or trauma to the pituitary or hypothalamus, intense exercise, stress or starvation, and finally there's premature ovarian failure. This category is pretty broad, so treatment is based on the specific condition that's diagnosed. Next is E for endometrial, which is usually due to a primary disorder of the endometrium. These patients have predictable and regular menses, but heavy menstrual bleeding or intermenstrual bleeding and no other definable causes. There are no particular tests for these disorders, so this is going to be a diagnosis of exclusion. I is iatrogenic causes, in which the bleeding is attributed to medical devices like IUDs, attributed to gonadal steroids like progestin-only preparations, or to drug therapies like anticoagulants or dopamine agonists. And then finally, N is for not otherwise classified, and this encompasses a variety of rare and poorly understood conditions. So that concludes the dysfunctional uterine bleeding topic. Dysmenorrhea is defined as painful menstruation, and it's broken down into primary and secondary. Primary dysmenorrhea has no associated pelvic pathology. It's due to increased prostaglandins, which cause painful uterine muscle activity. Secondary dysmenorrhea, in contrast, is due to pelvic pathology, such as endometriosis, adenomyosis, PID, tumors, adhesions, the list goes on. Dysmenorrhea commonly occurs right before or with the menses in the suprapubic or pelvic region. It generally lasts 1 to 3 days and may be accompanied by headache, backache, nausea, or vomiting. First-line treatment is NSAIDs because these inhibit prostaglandin activity in the uterus. But hormonal contraceptives can also be prescribed to suppress ovulation and significantly reduce symptoms. If these medications fail, a laparoscopy can be done to assess for secondary causes. Next is premenstrual syndrome, PMS. We all know this one. It's a group of physical and behavioral symptoms that occur 1 to 2 weeks prior to menstruation, so during the luteal phase, and it resolves 2 to 3 days after the onset of menses. This is a very common phenomenon occurring in the majority of females. Symptoms can include bloating, breast pain, headache, bowel changes, depression, irritability, libido changes, food cravings, poor concentration, fatigue, etc. Treatment involves exercise, stress reduction, salt and caffeine reduction, NSAIDs, vitamins B6 and E. Hormonal contraceptives can be prescribed to induce anovulation and stabilize hormone levels. In moderate to severe cases of PMS, or in patients who do not wish to take hormonal contraceptives, SSRIs are an option too. PMDD, or premenstrual dysphoric disorder, is a severe form of PMS with functional impairment. Here's the diagnosis according to the DSM-5 criteria. In the majority of menstrual cycles, at least 5 symptoms must be present in the final week before the onset of menses and become minimal or absent in the week post-menses. The DSM-5 goes on to list a number of symptoms similar in nature to PMS, but much more severe. Treatment of PMDD begins with SSRIs, but SNRIs can also be used. Hormonal contraceptives and diuretics may also be beneficial. If the patient has no response to SSRIs or hormonal contraceptive, gonadotropin-releasing hormone, or GnRH, can also be considered. Now let's conclude the menstruation section of the topic list with menopause. Menopause is a cessation of the menstrual cycle, and it's defined by 1 year or more of amenorrhea due to the loss of ovarian function. The average age of menopause is 51 years. Perimenopause is the transition between reproductive capability and menopause. It's characterized by irregular menstrual function that lasts for about 3 to 5 years, as well as vasomotor symptoms like hot flashes and night sweats, mood disturbances, irritability, vaginal dryness, or atrophy. Premature menopause is menopause that occurs before the age of 40 due to premature ovarian failure. This can be precipitated by certain conditions like diabetes, smoking, and malnourishment. Menopause occurs due to ovarian follicle depletion, since females are born with a finite number of eggs, and this depletion results in high FSH and low estrogen levels. Diagnosis of menopause should be made clinically, but an FSH greater than 30 is the most sensitive test, and this can further be confirmed by high LH and low estrogen. Remember that in the normal menstrual cycle, FSH and LH are what stimulate follicle growth in the ovaries, and the maturing follicle produces estrogen. This estrogen provides negative feedback to the brain to turn off the production of FSH and LH. However, as fewer follicles remain to be stimulated, estrogen levels decline, and there's no longer enough estrogen to provide this negative feedback, resulting in high FSH and LH levels. Additionally, this loss of estrogen carries some other significant health complications. It leads to an increased risk of osteoporosis and thus fractures, as well as an increased cardiovascular risk. Treatment options are based on symptom management. So, for vasomotor symptoms like hot flashes, hormone replacement therapy can be used. Hormone replacement therapy, or HRT, refers to estrogen and progesterone in patients that have an intact uterus. But estrogen alone can be used in patients who no longer have a uterus or who have had a hysterectomy. The reason for this is that estrogen carries an increased risk of endometrial cancer, so progesterone is protective for the uterus. Progesterone, protective, that's how I remember it. Then the non-hormonal therapies for vasomotor symptoms include SSRIs and SNRIs, clonidine, and gabapentin. So for symptoms of vaginal atrophy, a vaginal lubricant is first line for dryness and to prevent discomfort with intercourse, and if that fails, then transdermal or intravaginal estrogen can be prescribed. For prevention of osteoporosis, treatment includes calcium plus vitamin D, weight-bearing exercise, bisphosphonates, calcitonin, estrogen with or without progesterone, or selective estrogen receptor modulators, called SERMs, like raloxifene and tamoxifen. Now, just a little more on hormone replacement therapy. While it's effective, it has to be considered in light of its benefits and risks to the patient. The main benefit is that it's the most effective treatment of menopausal symptoms. It can also decrease the risk of osteoporosis and dementia. The downside is that it increases the risks of endometrial cancer due to the estrogen, and the risk of thromboembolism or blood clots and liver disease. Hormone replacement therapy also has some significant contraindications, including hypertriglyceridemia, history of endometrial cancer, history of breast cancer or other estrogen-sensitive cancers, cardiovascular disease, liver disease, any undiagnosed uterine bleeding, and any history of blood clots like stroke, DVT, or PE. These are all contraindications. The goal of hormone replacement therapy should be the smallest dose for the shortest time possible. All right, let's move on to gynecological infections, starting with cervicitis, or inflammation of the cervix. Cervicitis is caused by infection with gonorrhea, chlamydia, herpes, and HPV. Chlamydia is the most common bacterial STI and the most common cause of cervicitis. It is caused by Chlamydia trachomatis, which is a gram-negative bacteria, and this infection can be asymptomatic, but it can also present with watery or mucopurulent vaginal discharge, increased urinary frequency, dysuria, abdominal pain, or postcoital bleeding. In females, chlamydia can cause pelvic inflammatory disease, which we'll discuss a little more at the end of this section, and it can lead to infertility and ectopic pregnancy. It can also cause reactive arthritis. Gold standard diagnosis is made by nucleic acid amplification test of the discharge or the urine, so collect a vaginal swab or a urine sample, and first-line treatment is doxycycline, but recall that doxy is contraindicated in pregnancy, so second line is azithromycin or levofloxacin. There are high rates of co-infection with gonorrhea, so these patients should be tested for that infection as well. Gonorrhea is caused by the bacteria Neisseria gonorrhea, which is a gram-negative diplococci. Symptoms are very similar to chlamydia, as it can be asymptomatic, but can also present with mucopurulent discharge, cervicitis, increased urinary frequency, and dysuria. In females, gonorrhea can cause pelvic inflammatory disease and lead to infertility and ectopic pregnancy. It can also cause reactive arthritis. Diagnosis is made by nucleic acid amplification test, and treatment for gonorrhea is ceftriaxone as a one-time intramuscular injection. Because rates of co-infection with chlamydia are so high, about 30 to 40%, patients with gonorrhea need to be tested for chlamydia as well. Additionally, with both chlamydia and gonorrhea, their partners need to be treated and the patient should refrain from sex until the infection is cleared. Next up is herpes simplex, but I wanted to do a quick review first. When we say herpes simplex, we're referring to herpes simplex viruses 1 and 2, which cause cold sores and genital herpes respectively. But the list goes on past 1 and 2. Human herpes virus 3 is varicella zoster, which includes chickenpox and shingles. Human herpes virus 4 is Epstein-Barr virus, best known for causing mono, or the kissing disease. 5 is cytomegalovirus, or CMV, and 6 is roseola. So in the case of cervicitis, we're referring to herpes simplex 1 and 2, and that's what I'll be discussing for the rest of this section. In general, HSV1 is responsible for oral lesions in the mouth or at the lips, which we commonly call cold sores or fever blisters. These are brought on by stress or illness, last about a week or two, are contagious and unsightly when they occur, but are fairly manageable with few complications. In fact, over 90% of the US population has herpes simplex 1. Now, we used to think of HSV1 as causing mouth lesions and HSV2 causing genital lesions. But the reason I bring up herpes 1 under the cervicitis topic is because there's some overlap now due to oral sex practices. We can actually see patients with genital lesions from herpes 1 and oral lesions from herpes 2. The location of viral inoculation determines the location of symptoms, rather than the type of herpes virus. So if you're uncertain, a blood draw PCR test can confirm your diagnosis of either herpes 1 or 2. So herpes simplex 2, generally responsible for genital herpes. Patients often present with prodromal symptoms of burning, tingling, or irritation in the 24 hours prior to the appearance of lesions. And these lesions can occur on the labia majora, labia minora, mons pubis, vaginal mucosa, and the cervix. The classical presentation, or the buzzword description, is multiple painful vesicles on an erythematous base. This is good to know for testing, but the patients don't always present like the textbook, so the diagnosis can be confirmed by PCR or a viral culture. Additionally, a Zank smear from skin scrapings will show multinucleated giant cells, which is another good buzzword for test day. And finally, treatment of herpes simplex 2 is an oral antiviral like acyclovir or valacyclovir. Okay, the last infection under cervicitis is HPV, or human papillomavirus, which causes cervical cancer, genital warts, or both. There are over 100 types of HPV, but we'll go over the important ones here now. So HPV types 16, 18, 31, 33, and 35 are considered the high-risk types because they cause cancer. In fact, over 90% of all cervical cancer is associated with these types of HPV. So I'll list them again. It's 16, 18, 31, 33, and 35. In addition to cervical cancer, all of these high-risk HPVs can also cause genital warts, which look like flat, pedunculated, flesh-colored, cauliflower-like growths. There are two other HPV types that are important to know, and those are types 6 and 11. HPV 6 and 11 are not associated with cancer, but they do account for over 90% of genital warts. So clinical presentation of HPV can include genital warts, symptoms of cervical cancer or dysplasia, or the patient can be completely asymptomatic, or even present with symptoms years later. HPV is spread through sex or close skin-to-skin contact with someone who has the virus, even if no symptoms are present. This is what makes this virus so transmissible and the most common STI in the US. Diagnosis can be made by cervical swab, which can detect HPV DNA and determine which type or types are present. HPV testing is commonly done during a pap smear or cervical cancer screening, or at least after an abnormal pap smear. Additionally, acetic acid can help detect HPV. When it's applied to suspicious lesions, either on the labia or the cervix or the penis in males, the acetic acid will turn white in dysplastic or neoplastic tissues. This is often used in conjunction with colposcopies in order to more easily identify any areas that need to be biopsied. Treatment of cervical dysplasia and cancer are going to be addressed in the neoplasm topics, but let's tackle genital wart treatment now. So warts can go into spontaneous remission after months or years, but they can also return. A provider can apply trichloroacetic acid or podophyllin, or a imiquimod cream can be applied by the patient. Cryotherapy with liquid nitrogen is another option, as are surgical excision, electrocautery, or laser treatment. Finally, the Gardasil vaccine is a recommended vaccination to prevent 9 common and high-risk HPVs. Gardasil prevents HPV type 6, 11, 16, 18, 33, 31, 45, 52, and 58. It's given as a 2-dose series at 11 to 12 years old, but can be given up to age 26 in those that were not previously vaccinated. For adults that are age 27 through 45, it's not routinely recommended, but it can be given based on risk factors. Next on the topic list is vaginitis, or inflammation of the vagina, which is caused by trichomonas, bacterial vaginosis, candidiasis, or atrophic vaginitis. Trichomonas is a sexually transmitted infection characterized by pear-shaped flagellated protozoa. It presents with vulvar itching, erythema, dysuria, and copious amounts of frothy yellow-green vaginal discharge. The hallmark pelvic exam finding is cervical petechiae, which is called strawberry cervix. Diagnosis is made with a wet mount that's going to show a mobile pear-shaped protozoa with flagella. Honestly, I remember TRIC because it has 2 fruit-related buzzwords, strawberry cervix and pear-shaped protozoa. Kind of gross, but whatever makes the information stick, right? Another important clinical point for trichomonas is that the vaginal pH will be greater than 5. Normal is between 4 and 4.5. So on to treatment. Metronidazole, or Flagyl, PO, is the drug of choice, and this is safe in pregnancy. Like with many other STIs, the partner must also be treated so that it's not passed back and forth between them. Bacterial vaginosis, more commonly known as BV, is the most common cause of vaginitis. This one is not an STD though. BV occurs when a decrease in lactobacilli, which normally maintain vaginal pH, allows for the overgrowth of normal flora, especially Gardnerella vaginalis. Patients are often asymptomatic, but they can present with a vaginal odor or pruritus, itching, and a gray-white, fishy-smelling discharge. Diagnosis is made by the presence of clue cells, which are epithelial cells covered by bacteria, as well as the decrease in lactobacilli. Vaginal pH will be greater than 5, and a wet mount of the discharge with KOH prep produces a fishy odor, which is referred to as a positive whiff test. First-line treatment of BV is metronidazole or Flagyl, and second line is clindamycin. Because this is not an STI, there's no need to treat the partner. Since both trichomonas and BV are treated with the antibiotic metronidazole, I wanted to do a quick review. Metronidazole has only anaerobic coverage, especially anaerobes below the diaphragm, which is why it's first line for these conditions. Trichomonas and Gardnerella are both anaerobes. When prescribing this antibiotic, you have to advise the patients not to take it with alcohol. When metronidazole or Flagyl is combined with alcohol, there's a disulfiram-like reaction, and this causes flushing, tachycardia, palpitations, sweating, headache, acidosis, nausea, and vomiting. So advise patients to avoid alcohol during treatment and for 3 days following the completion of the antibiotic. Candidiasis or yeast infection is another incredibly common cause of vaginitis, especially in diabetics, pregnancy, steroid use, and patients taking antibiotics. This is a fungal infection caused by an overgrowth of Candida albicans. It presents with vaginal and vulvar erythema, swelling, burning, itching, dysuria, and a clumpy white discharge often compared to cottage cheese. Vaginal pH remains normal, but a diagnosis is made by presence of hyphae or yeast on KOH prep. Treatment for this is oral fluconazole or diflucan, and you can also use intravaginal or topical antifungals as well, like clotrimazole, nystatin, and tioconazole. The last topic under vaginitis is atrophic vaginitis or vaginal atrophy. This condition is associated with menopause and results from estrogen loss as females age. It causes vaginal tissues to become dry, thin, and inflamed, leading to discomfort and irritation, as well as painful intercourse, recurrent UTIs, and urinary incontinence. Vaginal atrophy is a clinical diagnosis made on vaginal exam, which will show thin, pale mucosa. Treatment should start with non-hormonal vaginal moisturizers and lubricants, but topical estrogen creams tend to be more effective. Oral hormone replacement therapy is also effective if there are no contraindications to it. Next up on the topic list is chancroid, which is an STD caused by the bacteria Haemophilus ducreyi. Here's a memory trick. It sounds like do cry, as in you do cry with Haemophilus ducreyi, because it causes painful genital ulcers. I sometimes mix up which infections cause painful versus painless ulcers, so this is how I remember. Do cry. Anyway, Haemophilus ducreyi is a very contagious gram-negative rod, but it's not very common in the US, much more common in the developing world. Chancroid begins as one or more painful genital ulcers on an erythematous base that may have foul exudate. About half of patients will also have painful inguinal lymphadenopathy. Diagnosis can be made clinically by culture, and treatment is antibiotics, typically azithromycin or ceftriaxone. Lymphogranuloma venereum is an STI caused by the bacteria Chlamydiotrichomatis, serotypes L1, L2, and L3 in developing countries. Lymphogranuloma venereum has 3 stages of infection: primary, secondary, and late stage. In the primary stage, a painless genital ulcer develops. In the secondary stage, unilateral or bilateral tender lymphadenopathy develops. And in late stage, this is characterized by strictures, fibrosis, and fistulas of the anogenital region. Definitive diagnosis is by serological testing or cultures, and first-line treatment in non-pregnant patients is doxycycline, since tetracyclines are contraindicated in pregnancy. Azithromycin or erythromycin are second-line options. Next up is syphilis. This is an STI caused by the spirochete bacterium Treponema pallidum. It's transmitted via direct contact of an infected lesion during sexual activity and has an incubation period of 3 days to 3 months. There are 3 phases of syphilis infection. During primary syphilis, a painless ulcer called a canker appears at the site of inoculation. This occurs 3 days to 3 months after initial exposure, and the canker lasts about 3 to 6 weeks. The bacteria travels to the regional lymph nodes as well, and this causes non-tender regional lymphadenopathy before disseminating. Secondary syphilis occurs anywhere from a few weeks to 6 months after the initial symptoms and presents as a diffuse bilateral maculopapular rash involving the palms and the soles. Secondary syphilis can also present with condyloma lata, which are wart-like lesions that involve the mucous membranes, and these are highly contagious. Other symptoms can include lymphadenopathy, fever, arthritis, headache, and hepatitis. Tertiary syphilis can occur from 1 to 20 years after initial infection, and it's a result of widespread systemic involvement. Tertiary syphilis can present with significant blood vessel changes, especially of the aorta, benign mucosal growths called gumas, bone and tissue damage, and permanent CNS changes. When this happens, it's referred to as neurosyphilis, and these symptoms include headaches, meningitis, dementia, incontinence, vision or hearing loss, Argyll-Robertson pupil, which is a small irregular pupil that does not constrict to light, and tabes dorsalis, which is a demyelination of posterior columns of the spinal cord, leading to weakness, ataxia, paralysis, and chronic burning pain. Syphilis can also be latent, presenting asymptomatically but with positive serologic testing. We call it early latent if the patient has been positive for less than a year. They are usually highly infectious. And we call it late latent if they've been positive for more than a year. This corresponds to less infectivity, except in the case of fetal transmission, because the infant can get congenital syphilis, which is associated with a number of deformities and neuroabnormalities. So diagnosis is made through serologic testing of blood, but there are a couple different tests to know about. Generally, initial screening of syphilis is done with a non-treponemal screening test, either RPR or VDRL. RPR stands for Rapid Plasma Reagent, and VDRL stands for Venereal Disease Research Laboratory. Both of these screening tests are nonspecific and have a high chance of false positive results. So if the initial screening test is positive, it needs to be confirmed with a treponemal test, like fluorescent treponemal antibody absorption or a microhemagglutination test. These treponemal tests both look for antibodies to the Treponema pallidum bacteria. Furthermore, once a patient has syphilis, these treponemal tests are usually going to remain positive for life even after treatment. Historically, syphilis was not curable until the development of penicillin, and mercury was actually used in order to make the patient salivate because this was mistakenly believed to expel the infection. Hence the phrase, "a night with Venus, a lifetime with Mercury." Now, the first line and the mainstay of treatment in all stages of syphilis is penicillin G. Even in those with a penicillin allergy, desensitization is sometimes used. Doxycycline and tetracycline are alternative options, but not as effective as penicillin. Now, there's a possible side effect of penicillin treatment for syphilis called a Jarisch-Herxheimer reaction. This reaction is an acute febrile response that typically occurs in the first 24 hours after beginning antibiotics for spirochete infection, and it's due to the rapid lysis of the spirochetes. The fever is associated with myalgias and headaches, but taking an antipyretic during the first 24 hours can reduce this reaction. One last thing. Syphilis is one of the torch infections, which are the infections a baby can acquire in utero or during birth that cause significant morbidity and mortality in infants. Traditionally, torch infections, as an acronym, stood for toxoplasmosis, other, referring to syphilis, rubella, cytomegalovirus, and herpes simplex. These 5 infections have a similar presentation in the infant, like rashes and ocular pathology, so it makes sense to group them together. But now that other category has grown to include varicella, HIV, parvovirus, and a few others. We're going to touch more on the torch infections in some of the other EOR videos, though. The last topic under infections is pelvic inflammatory disease. PID is an infection that ascends to the upper portion of the reproductive tract in women, meaning the endometrium and/or the fallopian tubes. A number of different organisms can be responsible for this, but most commonly the causative organisms are gonorrhea and chlamydia. Patients with PID present with pelvic or lower abdominal pain, fever, dysuria, pain with intercourse, nausea, vomiting, and purulent vaginal discharge, sometimes bleeding. A pelvic exam often shows a positive chandelier sign, which is cervical motion tenderness to palpation. Often it's so severe that the patient is said to jump as if reaching for the chandelier. Diagnosis is primarily clinical. The patient must have abdominal tenderness, cervical motion tenderness, and adnexal tenderness, plus one or more of the following: fever, white blood cell count more than 10,000, pelvic abscess or abnormality on a bimanual exam or ultrasound, positive gram stain of culture, increased ESR or CRP. Additionally, a laparoscopy, if done, can provide a diagnosis as well. Treatment is divided into inpatient and outpatient. So outpatient treatment is doxycycline with ceftriaxone plus or minus metronidazole. You can kind of think of this as covering the common organisms: doxy for chlamydia, ceftriaxone for gonorrhea, and metronidazole for anaerobes. If the patient is severely ill, has nausea and vomiting, or complicating factors, consider inpatient hospitalization. Inpatient treatment is IV doxycycline plus a second-generation cephalosporin like cefoxitin or cefotetan. Or they can get clindamycin plus gentamicin as long as their renal function is normal. Finally, pelvic inflammatory disease can cause a number of complications due to infected abscesses and development of scar tissue. These complications include infertility, ectopic pregnancy, chronic pelvic pain, tubo-ovarian abscess, and Fitzhugh-Curtis syndrome. Fitzhugh-Curtis syndrome is also called perihepatitis, and it's fibrosis and scarring of the liver and the peritoneum in the right upper quadrant due to inflammation. Liver function tests are often normal, but it causes right upper quadrant pain that can radiate to the right shoulder, as well as violin string adhesions on the anterior surface of the liver. And with that, we've completed the infection section of the topic list. Let's start the neoplasm section with breast cancer because it is the most common malignancy in women. 1 in 8 women in the US will get breast cancer at some point in their life. Risk factors are related to increased estrogen, so early menarche, late menopause, nulliparity, never having breastfed, hormone replacement therapy, and age over 65. Other risk factors include obesity, consuming 3 or more alcoholic drinks per week, family history of breast cancer, and genetic mutations, specifically the BRCA1 and BRCA2 genes. And this is the genetic mutation that Angelina Jolie brought attention to back in 2013 when she talked about her preventative double mastectomy. So women who have BRCA mutations are at a significantly increased risk for breast and ovarian cancers. In fact, they have a 60 to 85% lifetime chance of breast cancer and a 15 to 40% lifetime chance of ovarian cancer. Most breast cancer can be divided into ductal or lobular carcinoma, depending on whether it's located in the milk ducts or the lobules. And both ductal and lobular types can be further broken down into carcinoma in situ, meaning the cancer does not penetrate the basement membrane, or infiltrative carcinoma. So let's start with ductal. Ductal carcinoma in situ, or DCIS, is malignant proliferation of cells that have not progressed through that basement membrane of the duct. DCIS can progress to invasive cancer, to infiltrative ductal carcinoma, if it's left untreated. Infiltrative ductal carcinoma is by far the most common type of breast cancer. It's about 70 to 80% of all breast cancers. And it's associated with mets to the lymphatic system, especially axillary lymph nodes. Infiltrative carcinoma should be treated more aggressively than DCIS. All right, now lobular. Lobular carcinoma in situ, or LCIS, is not technically defined as cancer because these abnormal cells tend to remain in the lobule. So LCIS is not a precursor lesion for invasive cancer in the same way that DCIS is a precursor lesion. It's still clinically significant though, because LCIS is a marker for increased risk of invasive breast cancer. In fact, women with LCIS have 7 to 12 times higher risk of invasive cancer, and that invasive cancer can be either ductal or lobular, and it can occur in either breast. So regular breast cancer screening is very important in these patients. There are a few other breast cancer types to know. Paget's disease of the breast is a rare cancer associated with chronic eczematous, itchy, scaling rash on the nipples and the areola that might ooze and might have a lump present. Inflammatory breast cancer is another rare but very aggressive cancer. It presents as a red, warm, swollen, and itchy breast, typically with nipple retraction and a characteristic skin thickening due to lymphatic blockage that resembles an orange peel. It's called peau d'orange, but I might have butchered that. Inflammatory breast cancer tends to have a very poor prognosis. Additionally, breast cancers can have receptors on their cells. They can be estrogen receptor positive, progesterone receptor positive, HER2 positive, or triple negative. This pathology can help guide cancer treatment. So besides the previously mentioned symptoms of Paget's and inflammatory cancer, physical exam findings can include a palpable breast lump, asymmetric discoloration, ulceration, skin dimpling, nipple inversion, skin thickening, and changes to breast size and contour. Diagnosis begins with either mammography or ultrasound depending on the patient's age. If the patient is younger than 40 with a palpable breast mass, an ultrasound is indicated first. If the patient is older than 40, a mammogram is ordered first. And the reason for this is that young breast tissue tends to be very dense, making it difficult to read on a mammogram. A mammogram with microcalcification and or spiculated masses is suspicious for cancer. And if imaging does not rule out malignancy, or if a diagnosis is still unclear, then a biopsy is done for definitive diagnosis. So once breast cancer has been confirmed, there are a few different treatment options. A lumpectomy allows for maximal breast conservation. However, if the tumor is large, diffuse, or the patient has had previous radiation to the breast, then a mastectomy might be more appropriate. Removal of regional lymph nodes can also be done to determine if there's any metastasis. After removal of the tumor, radiation is often used to destroy any residual tumor cells. And in stage 2 through 4 breast cancer, or in inoperable breast cancers, chemotherapy is used. Neoadjuvant endocrine therapy is another option, depending on that receptor status of the cancer. Anti-estrogen medications and aromatase inhibitors are useful in estrogen receptor positive tumors, while monoclonal antibody treatment is useful in HER2 positive cancers. The most common anti-estrogen med that you'll probably see for breast cancer is tamoxifen. On to screening. Now, mammogram screening guidelines vary, but USPSTF recommends a mammogram every 2 years from ages 50 to 75, or starting at age 40 if there are increased risk factors. Clinical breast exam should be done every 3 years in women aged 20 to 40, and then annually starting at 40. And finally, a breast self-exam should be done monthly right after menstruation, starting at age 20. The next neoplasm topic is cervical dysplasia. So cervical cancer screening is done by pap smear cytology. Guidelines recommend that screening by pap smear should be initiated by age 21, regardless of sexual activity, and then every 3 years after that until age 30. Starting at age 30, pap smear cytology plus HPV testing is recommended every 5 years. Most guidelines recommend discontinuing screening at age 65 if the last 3 consecutive screening tests were negative, but again, guidelines vary. The pap smear cytology report can come back with a few different abnormal pathologies. ASCUS stands for atypical squamous cells of undetermined significance. This can have a few different causes, but basically we need to know whether or not it is HPV related. Remember, HPV types 16, 18, 31, and 33 are high-risk HPVs for cervical cancer. If the patient is 21 or younger with an ASCUS result, just repeat the pap smear in 1 year. If they're older than 21, do the HPV testing. If the HPV is negative, repeat the Pap smear in 1 year. And then if the HPV is positive, do a colposcopy. LSIL stands for low-grade squamous intraepithelial lesion. This pathology indicates mild dysplasia and includes cervical intraepithelial neoplasia 1, or CIN1, which is a precursor to cervical carcinoma. LSIL is most commonly seen with the cell changes associated with HPV. So if the patient is 25 or older, get HPV testing. If HPV positive, do a colposcopy. And then if HPV negative, or if the patient is younger than 25, repeat the Pap in 1 year. HSIL stands for high-grade squamous intraepithelial lesions. This pathology includes CIN2, or moderate dysplasia, CIN3, or severe dysplasia, and carcinoma in situ, cancer that has not yet penetrated the basement membrane. HSIL is usually from persistent HPV infection. This result requires a colposcopy with biopsy in all age patients, often followed by excision. If the lesion is inside of the cervix, a cone biopsy can be done, and if it's outside of the cervix, a loop electrosurgical excision procedure, LEEP, or cryotherapy can be done. Just a reminder, if you need a refresher on HPV, it's back in the infection section, and you can find the timestamps down below. Over 99% of cervical cancer is associated with HPV, especially types 16, 18, 31, and 33. Besides HPV, other risk factors include smoking, a history of CIN pathology, immunosuppression, STIs, and DES synthetic estrogen exposure, although that's no longer on the market. There are 2 types of cervical carcinoma. Almost 90% are squamous cell, and about 10% are adenocarcinoma. The most common symptoms of cervical carcinoma are abnormal vaginal bleeding or spotting, especially postcoital bleeding, and can also include pelvic pain and vaginal discharge. Screening is done via Pap smear, and diagnosis is confirmed via colposcopy with biopsy. Treatment depends on the stage. Stage 0, or carcinoma in situ, is treated with excision, ablation, or even a total abdominal hysterectomy with bilateral salpingo-oophorectomy. Stage 1 is treated similarly, but with added radiation and/or chemotherapy. And stage 2 through 4 also get chemo and radiation. And stage 4B, meaning it has distant metastasis, is treated palliatively. Next is endometrial cancer. Endometrial cancer is the most common gynecological malignancy in the U.S. It is typically postmenopausal with a peak in the 60 to 70-year-old age range. Postmenopausal bleeding is the cardinal symptom. This is a buzzword for test day, as 1/3 of women with postmenopausal bleeding have endometrial cancer. So bleeding in postmenopausal women is cancer until proven otherwise. Endometrial cancer is an estrogen-dependent cancer, so the main risk factor is increased estrogen exposure. This occurs through nulliparity, or not having carried children, chronic anovulation, as occurs in PCOS, early menarche, late menopause, estrogen replacement therapy, the drug tamoxifen, as well as obesity, diabetes, and hypertension. Additionally, Lynch syndrome, a genetically inherited condition associated with colon cancer, carries an increased risk of developing endometrial cancer as well. Most endometrial cancer, more than 80%, is adenocarcinoma. Gold standard for diagnosis is an endometrial biopsy. A transvaginal ultrasound can be used as well and will show an endometrial stripe greater than 4 millimeters. This ultrasound finding can also indicate endometrial hyperplasia, which is a precursor to endometrial cancer, so it's likely you'll end up doing the biopsy anyway. An endometrial biopsy is indicated in all postmenopausal patients with vaginal bleeding. Treatment is usually a total abdominal hysterectomy with bilateral salpingo-oophorectomy. Basically, they take out the uterus, ovaries, cervix, both fallopian tubes, and this is with or without post-op radiation. Stage 2 and 3 cancers get a lymph node excision as well, and stage 4 gets systemic chemotherapy. Most endometrial cancers are actually well differentiated, making them more curable. Ovarian neoplasms are the next topic. Ovarian cancer has the highest mortality of all the gynecological cancers, and most are diagnosed at an advanced stage. Risk factors include increased number of ovulatory cycles, so nulliparity, infertility, early menarche, late menopause, and older age, as well as a family history, BRCA1 and BRCA2 gene mutations, Peutz-Jeghers syndrome, and Turner syndrome. Protective factors include the oral contraceptive pill since it decreases ovulation, multiple pregnancies, and of course a total hysterectomy. Ovarian cancer is rarely symptomatic until late stage with extensive metastasis. Symptoms include abdominal fullness, distension, ascites, back or abdominal pain, early satiety, constipation, and urinary frequency. Patients may also present with irregular menses, menorrhagia, or postmenopausal bleeding. A palpable abdominal or ovarian mass might be present on physical exam, and a Sister Mary Joseph's nodule indicates mets to the umbilical lymph node. Diagnosis is made via transvaginal ultrasound followed by a biopsy, and about 90% are epithelial tumors. In early stages, treatment is excision, a total abdominal hysterectomy with bilateral salpingo-oophorectomy, plus selective lymphadenectomy. In later stages, tumor debulking can be performed, followed by adjuvant chemo or radiation. Also, serum CA-125 levels are used to monitor disease progress. Besides actual ovarian cancer, there are also benign ovarian neoplasms. The most common of these are dermoid cystic teratomas, a type of ovarian germ cell tumor. These are those bizarre tumors that can contain hair and teeth and other gnarly cell types. They typically present in younger patients, and management is surgical removal due to the risk of ovarian torsion or malignant transformation. The last neoplasm topic is vaginal and vulvar neoplasm. Vaginal cancer is rare and usually secondary to another cancer. 95% of vaginal cancer is squamous cell carcinoma caused by HPV. But clear cell adenocarcinoma is possible if there was DES exposure in utero. DES was the first synthetic estrogen, but it was taken off the market back in 1971. Vaginal cancer is often asymptomatic, but it may present with menstrual changes, abnormal vaginal bleeding, or discharge. Treatment is radiation therapy. Vulvar cancer is 90% squamous cell carcinoma caused by HPV, but it can also be melanoma. The most common symptom is vaginal pruritus or itching or irritation, and can also present with bleeding or discharge. Lesions might look red or white, ulcerative, and crusted, or might present as pruritic black lesions. Diagnosis is made via biopsy of the lesion. Treatment is surgical excision, possibly a vulvectomy, and lymph node dissection, then radiation therapy and chemo. The next section is breast disorders, so we're going to start with mastitis. Mastitis refers to the inflammation of the breast, often from a blocked milk duct, but can also be from bacteria, either from skin flora or from the oral flora of a breastfeeding infant that enters through trauma to the nipple. This causes unilateral erythema and tenderness, but it can lead to more serious symptoms like fever or chills. Staph aureus is the most common culprit. Treatment is predominantly supportive with warm compresses and analgesics. The mother should continue to breastfeed from the affected breast because this helps to prevent congestion and it doesn't pose any risk to the baby. Finally, anti-staph antibiotics might be required, and if so, the first line is decloxacillin. And if you have trouble remembering this one, just think about how we describe breast anatomy, like clocks. So palpable mass at 9 o'clock. Well, decloxacillin is for declox. The next topic is breast abscess. So a breast abscess is just a pocket of contained infection within the breast, and it's generally a progression from mastitis. The symptoms are the same, but with a palpable abscess, and sometimes signs of systemic infection like fever. Again, Staph aureus is the most common pathogen. As with mastitis, these patients get an anti-staphylococcal antibiotic, such as decloxacillin, and in addition, a breast abscess gets an IND, or incision and drainage. And at this point, breastfeeding does have to stop, but only from the affected breast. Next is fibrocystic disease, and fibrocystic changes are the most common breast disorder. typically due to an exaggerated response to hormones. It's characterized by multiple fluid-filled cysts that feel like mobile, well-demarcated lumps within the breast tissue. These cysts are often tender, bilateral, and may increase or decrease in size with the menstrual cycle. Fibrocystic disease is diagnosed with a breast ultrasound, and a fine needle aspiration would produce a straw-colored fluid. It isn't harmful or dangerous and tends to resolve spontaneously, but NSAIDs, heat, and a supportive bra can be recommended to ease the discomfort. The last one under breast disorders is fibroadenoma. This is the second most common benign breast disorder and is especially common in teens and early 20s. A fibroadenoma is a small, firm, round, painless, well-circumscribed, and freely mobile breast mass. They're composed of glandular and fibrous tissue, and the classic description is rubbery. Fibroadenomas grow gradually over time, and most will resorb with time as well. The next section is structural abnormalities, so we'll start with uterine prolapse, which occurs when the uterus herniates into the vaginal canal. Risk factors are related to the weakness of pelvic floor muscles and ligaments, so prolapse is most common after childbirth, especially in patients with multiple vaginal births, as well as obesity and with repeated heavy lifting. Clinically, this manifests with a feeling of vaginal fullness or a falling out sensation. It can also cause lower back pain, vaginal bleeding or discharge, and urinary frequency or incontinence. The pelvic exam is diagnostic because you'll see a bulging mass, especially if you have the patient bear down or do a Valsalva maneuver. Uterine prolapse is graded 1 through 4. So grade 1, or first degree prolapse, is uterine descent into the upper 2/3 of the vaginal canal. In grade 2, the cervix approaches the vaginal opening. In grade 3, the cervix is outside of the vaginal opening. And in grade 4, the entire uterus is outside of the vagina. So on to the treatment modalities. Kegel exercises and weight control are encouraged to help prevent pelvic organ prolapse. So for first and second degree prolapse, a pessary can be placed inside to hold up the prolapsed uterus. This is a non-surgical option and can be done in office. It's pretty simple. For more severe cases, a hysterectomy can be done with fixation of the top of the vagina and surgical repair of the pelvic support structures. Similar to uterine prolapse, other pelvic organs can also herniate into the vaginal canal. A cystocele occurs when the bladder herniates into the anterior vagina. Patients often complain of urinary incontinence or frequency with this one. A rectocele occurs when the rectum herniates into the posterior vagina. These patients might have bowel symptoms or difficulty with defecation. And finally, an enterocele occurs when the small bowel, specifically the pouch of Douglas, herniates into the upper vagina. These are graded the same way as uterine prolapse, grades 1 through 4, and have the same risk factors, namely weakness of the pelvic floor muscles. As with uterine prolapse, Kegel exercises are prophylactic. A pessary can support the prolapsed organ, and surgical repair can be done for severe or refractory cases. Another structural abnormality is ovarian torsion, which is the rotation of the ovary at its pedicle to such a degree that the blood flow is obstructed. Ovarian cysts greater than 5 centimeters are the biggest risk factor for this condition. Patients present with sudden onset sharp pain that is unilateral in the lower abdomen, often accompanied by nausea and vomiting. Diagnosis is made by ultrasound with Doppler, which typically shows obstructed Doppler flow. And treatment is laparoscopic surgery to untwist the ovary and restore the perfusion. An ovarian cyst is a fluid-filled sac within the ovary. They're very common in reproductive years, typically harmless and asymptomatic, and most spontaneously resolve within a few weeks. Most women have no idea they're even there unless there's a complication, like the cyst ruptures, it causes ovarian torsion, or becomes hemorrhagic. In these cases, the predominant symptom is unilateral right or left lower quadrant pain, depending on which ovary has the complication. There are 2 different classifications of ovarian cysts. Functional, meaning they're a variant of the normal menstrual cycle, and non-functional. Non-functional cysts include dermoid cysts or teratomas, which we talked about under benign ovarian neoplasms, and they also include endometriomas, aka chocolate cysts, as well as cysts associated with polycystic ovarian syndrome, or PCOS. There are a few other non-functional cysts, but these are the main ones. Now, functional cysts, considered normal variants, can be divided into 3 types. The most common functional cyst is follicular, which occurs when a dominant follicle in the ovary fails to rupture and continues to grow instead. The next type is a corpus luteal cyst, which occurs when a dominant follicle does rupture but then closes again and doesn't degenerate after ovulation. The last type is theca lutein cysts, which are only seen with pregnancy. They develop due to overstimulation of beta-HCG, which causes hyperplasia of the theca interna cells, resulting in a cyst. And again, out of these 3 types of functional cysts, follicular is going to be the most common. Diagnosis is made by pelvic ultrasound of the ovaries. Also, order a beta-HCG to rule out pregnancy. Management is supportive. Most cysts less than 8 centimeters are functional and will resolve spontaneously. No follow-up imaging is even needed if the cysts are smaller than 5 centimeters. If they're larger than 8 centimeters and persistent or found post-menopause, then MRI or laparoscopy might be warranted. There are a few complications that can occur with ovarian cysts. Ovarian torsion we just went over, but the others occur when the cyst ruptures and/or becomes hemorrhagic. Remember in the normal menstrual cycle that the rupture of follicles happens with every ovulatory cycle. Typically, these follicles are less than 3 centimeters in size, and for many women, they don't cause any pain. In fact, when they do cause pain, it's referred to as Mittelschmerz, pain with ovulation. So pain from a ruptured ovarian cyst can vary greatly based on the patient. Anyway, fluid from a ruptured cyst leaks into the intraperitoneal space, which can cause pain or irritation. But serous fluid from a simple cyst is not typically as irritating as blood from a hemorrhagic cyst, which can accumulate in the ovary or flow into the abdomen and irritate the visceral peritoneum. So while each patient's pain level will be different, a hemorrhagic cyst tends to be more painful than the rupture of a simple cyst. Next up is endometriosis. This is the presence of endometrial tissue outside of the uterus, most commonly in the ovaries, fallopian tubes, posterior cul-de-sac, broad, and uterosacral ligaments. This extrauterine endometrial tissue responds to menstrual hormone changes just like uterine endometrial tissue, so physical exam often presents with premenstrual pelvic pain and the 3 Ds: dysmenorrhea, dyschezia, and dyspareunia, so painful menstruation, defecation, and intercourse. It can also present asymptomatically in about 1/3 of patients. History of infertility is also pretty common. Pelvic exam is often normal, possibly with fixed tender adnexal masses, and definitive diagnosis is made by laparoscopy with biopsy. Imaging tests are not adequate or specific enough for diagnosis. You actually have to visualize this extrauterine endometrial tissue, and it appears as raised patches of thick, discolored scar tissue, or it can have a powder burn appearance. Sometimes endometriosis involves the ovaries and gets large enough to be considered a benign tumor, usually filled with old blood, giving it a chocolate appearance. This is called an endometrioma or chocolate cyst, as was mentioned in the non-functional ovarian cyst category. Treatment begins conservatively with NSAIDs, and the patient can be offered hormonal birth control for ovulation suppression to treat the menstrual pain. In more severe cases, leuprolide and danazol can be used to suppress FSH and LH. Lastly, surgical options include laparoscopic endometrial tissue removal by ablation, which conserves fertility, or a hysterectomy is another option. Now let's do an overview of contraception methods, starting with the non-hormonal birth control options. Barrier methods include male and female condoms, diaphragms, contraceptive sponge, and any method that acts as a physical barrier preventing sperm from entering the cervix. Failure rates tend to be around 20% for most of these methods, often due to human error, like not following the instructions fully. Besides abstinence, condoms are the best way to protect against most STDs, but they don't protect against all of them, like herpes and HPV. Spermicides are another form of contraception, but with an almost 30% failure rate, they are often used in conjunction with other methods like condoms. Spermicides can also cause microabrasions, so there's actually a slightly increased risk for HIV. Coitus interruptus, commonly called pulling out or the withdrawal method, involves the male withdrawing prior to ejaculation, but this has a 20% failure rate because the sperm and pre-ejaculatory fluid can also lead to pregnancy. Another method is natural family planning, which involves abstaining from sex during a woman's fertile period, which is determined by monitoring a variety of factors, including daily body temperature, cervical mucus, menstrual calendar, and sometimes urine hormone tests. This method has high success rates when done properly for women with regular menstrual cycles, but because it requires fertility awareness and tracking multiple factors, it has high failure rates in practice. Also, neither natural family planning nor the withdrawal method offer any protection against STDs. Now for the hormone-based birth control methods. The most common one is the combined oral contraceptive pill. This is an estrogen and progesterone containing pill that prevents ovulation by inhibiting the mid-cycle LH surge. It also thickens cervical mucosa and thins the endometrium. Failure rates with the pill are about 9% on average, mostly due to incorrect usage like missing a dose or not taking it at the same time each day. Pros associated with the pill are improved dysmenorrhea, protection against ovarian cysts, ovarian cancer, and endometrial cancer, and improved acne. Cons of the pill are an increased risk of thromboembolism or blood clots, hypertension, gallstones, fluid retention, hepatic adenoma, mood changes, and breast tenderness. Nausea and breakthrough bleeding tend to resolve within the first 3 cycles on the pill. The combined contraceptive pill cannot be used in patients over 35 years old who smoke, or any patient with a history of blood clots, breast cancer, or migraines with aura. Additionally, it does not protect against STIs. Next is the transdermal patch. This is a sticky patch containing both estrogen and progesterone that is applied to the skin every week for 3 weeks, then 1 week off. Failure rates are almost on par with the oral contraceptive pill, and they have all the same pros and risks, with a possible increased risk of blood clot compared to the pill. The progestin-only mini pill is another oral hormonal birth control pill. It contains progestin only, as the name suggests, and it works similarly to the combined pill but is slightly less effective and may cause menstrual irregularities. This one is safe during lactation, and it does not have the same estrogen side effects like nausea, headache, and high blood pressure. There are also long-lasting progestin options like Nexplanon or Depo-Provera. Nexplanon is a progesterone-releasing rod that is implanted into the upper arm. It lasts 3 years and has a 0.05% failure rate. Depo-Provera is a progesterone injection that lasts 3 months and has a 5% failure rate. Both of these may cause menstrual irregularities and weight gain, and they do not have any protection against STIs. The NuvaRing is a flexible plastic vaginal ring that releases estrogen. It's inserted into the vaginal canal and it stays there for 3 weeks out of each month. It can remain in place during intercourse, but if taken out, must be replaced within 3 hours. The failure rate is 7%, and it does not protect against STIs. The most effective reversible form of birth control is an IUD, or intrauterine device. The 2 most common are the Mirena and the Paragard IUDs. The Mirena is a progestin-only IUD that gets replaced every 5 years. Side effects are similar to other progesterone-only contraception. The Paragard is a non-hormonal copper IUD that's replaced every 10 years. Both IUDs have a less than 1% failure rate, but carry an increased risk of pelvic inflammatory disease, and neither protects against STIs. Emergency contraception, also called Plan B, is a progestin pill that can decrease the risk of pregnancy if taken within 3 days of unprotected sex. Efficacy decreases the longer that the patient waits, though. This pill works by preventing ovulation if taken prior to the LH surge. Additionally, the Paragard copper IUD is also approved for use as emergency contraception if placed within 5 days of unprotected sex. Lastly, sterilization is a permanent contraceptive option. In females, this is tubal ligation, or getting the tubes tied, and in males, this is a vasectomy. Worth noting is EOR, a device for female sterilization that resembles a small metal coil. When placed into the fallopian tubes, it induces permanent scarring and blockage. This product became controversial when thousands of women were reporting severe side effects that required surgical removal of the device. As of 2018, the FDA has restricted the sale and use of Escher in the US, but plenty of women already had it implanted, so it's likely you'll still see it around. Now that we've covered contraception, we're going to move on to infertility. Infertility is defined as the inability to conceive after 1 year of regular, unprotected intercourse. The etiology is believed to be about 40% on the male side of the equation and 60% on the female side. Anovulation is the most common cause. Diagnosis should begin with a detailed history and ovulation tracking, like a menstrual diary or app, basal body temperature, and ovulation tests. A diagnostic workup can include hormone levels, especially TSH, prolactin, LH, and FSH, as well as an ultrasound and semen analysis to diagnose male factor. More invasive or expensive tests can include a hysterosalpingogram and laparoscopy to evaluate tubal patency and other abnormalities. Treatment is based on underlying cause, such as metformin for PCOS or bromocriptine for hypoprolactinemia. One common medication to know is clomiphene citrate, or Clomid, which is a selective estrogen receptor modulator, a SERM, used to increase follicular number and induce ovulation. More invasive treatment options include intrauterine insemination and in vitro fertilization. The second to last topic is sexual assault. There's a lot that could be said here, but I'm going to try to keep it very brief and exam-focused. Sexual assault is any involuntary sexual act, either against one's will or non-consensual. 1 in 3 women will be sexually assaulted in her lifetime, but because of the associated stigma, only 1 in 10 of those will seek help. Rape is one form of sexual assault. It is a legal situation, so document everything and save the clothing. A rape kit, if the patient is amenable to it, has instructions regarding history taking and specimen sample collection. Typically, cultures are taken from the vagina, anus, and pharynx for STI testing, in addition to testing for syphilis, HIV, hepatitis, a urinalysis, and a pregnancy test. A lot of hospitals also have a nurse who has completed specific training related to sexual assault and is well versed in procedures for using a rape kit. Medical treatment generally involves prophylactic antibiotics and the option of emergency contraception. This situation is not just a medical event, it's also a psychiatric emergency. So counseling needs to take place as soon as possible, preferably before the patient leaves the ER or the clinic, as well as a follow-up by phone within 24 to 48 hours after discharge. Again, this is not an exhaustive coverage of this complex topic, but I want to leave you with the phone number to the National Sexual Assault Hotline that's available 24/7. It's 1-800-656-4673. And now for the final topic, urinary incontinence. This is defined as the involuntary loss of urine. There are 5 major types of incontinence. Urge incontinence, where you feel the need to go frequently. Stress incontinence, where you get urine leakage with coughing or jumping or anything that increases abdominal pressure. Overflow incontinence, where the bladder is so full that it overflows. Functional incontinence, where everything is urologically normal but the patient cannot get themselves to the bathroom. And the last one is mixed, or some combination of the aforementioned types of incontinence. So let's roll through these again, but in a little more depth. The first one was urge incontinence, also called overactive bladder. This occurs due to an overactive detrusor muscle, which is the muscle within the walls of the bladder that contracts during urination to push the urine into the urethra. Detrusor overactivity results in frequent but small amounts of urine that are preceded by an urge to go. This type of incontinence is common in the elderly and often disrupts sleep, but it can also be associated with UTIs, so it's important to rule that out first. Urge incontinence is treated first with bladder training exercises like timed voiding, as well as decreased fluid intake. If this doesn't work, first-line medications are anticholinergics, like oxybutynin and tolterodine. The detrusor muscle is stimulated by muscarinic acetylcholine receptors, so anticholinergics work by blocking these cholinergic receptors. A second-line option is imipramine, a tricyclic antidepressant, or mirabegron, a bladder relaxant. Next was stress incontinence. This is urine leakage due to increased intra-abdominal pressure and weak pelvic floor muscles. It is common in women, especially after childbirth, surgery, postmenopausal estrogen loss, and obesity. This is treated first with Kegel exercises to strengthen the pelvic floor, as well as weight loss if appropriate. Other treatment options include vaginal estrogens, placement of a pessary, alpha agonist medications, and surgery, especially a urethral sling surgery. Third was overflow incontinence. This one is kind of the opposite of urge incontinence because it is caused by impaired detrusor muscle contraction. This results in incomplete bladder emptying or urinary retention, then bladder distension, and eventually urine overflow into the urethra. This type of incontinence is more common in diabetic patients and those with neurologic disorders, and it can also occur in men with enlarged prostates. Overflow incontinence is diagnosed by elevated post-void residual volume, which can be assessed by doing a bladder scan after the patient has urinated. First-line treatment is with intermittent self-catheterization, which is fairly effective. Additionally, cholinergic medications like bethanechol can be used to increase bladder contractions, or alpha blockers, the Zosins, can be used to decrease sphincter resistance. Next was functional incontinence, which is pretty simple. The patient has a physical or mental disability that prevents them from being able to actually get to the bathroom to void. And the last one was mixed, most commonly a mix of stress and urge incontinence. And with that, we're done. This wraps up the gynecology half of the Women's Health EOR exam study guide. This was my very first audio review guide, and I had a lot of fun making it, so if it benefits at least one student out there to kick some butt on the exam, then I'm pretty excited about that. The obstetrics video, the other half of the PAEA topic list for the Women's Health exam, should be up in about 2 weeks. Unless you're listening to this in the future, in which case maybe I've got all the study guides up already. Feel free to take a look around my channel, subscribe if you'd like, and thank you so much for listening. Happy studying, and I'll see you in the next video.